Hello?
Hi, this is Alina Bacho at the National Academies.
Hi, Alina. This is Megan Collado at Academy Health. I'm here with a colleague of mine, Mara Dugan.
Hello.
How are you?
Great, thank you. Thanks so much for making this available to our collaborative members and other folks. We reached out to our roundtable members and the roundtable listserv, which is about 3,000 people, so I expect at least a reasonable showing on the webinar today.
Oh, great.
And I see that we have Bob McClellan on the line. He's one of the collaborative co-chairs who will be introducing Mona at the beginning.
I show option in.
Hello, Alina? Hello? Alina?
Bob, can you hear me?
Yeah, I can hear you now. Good.
Great.
I don't have anything on my screen. Is the splash screen supposed to be up?
Yeah, hang on a second.
I see your name. Oh, now I got it. Okay.
Yep.
Good. And we have Mona on the line.
We do.
Good. We got 25 people already. Wow, this is great.
Someone else has their computer speakers on. Yeah, but hello.
Hi, everyone. So I think we have all of the speakers unmuted. Bob?
Alina, this is Mona. Can you hear me?
Yes.
Great.
And I know Bob's on the line, and I know Megan is as well. Actually, both Megans. Can you both hear me?
I can hear you. Megan?
Hi, yes, I can hear you.
Great. Ron? You know, Ron before said he couldn't hear anything.
Yeah.
It looks like Ron is muted. Oh,
Yeah, he was unmuted, and I just muted him, but unmuted him again.
Hi, can you hear me now?
Yep.
Yes.
Great.
Perfect. Okay, great. Well, we are right at the top of the hour. So I think we got lots of participants, so I think we'll get started. My name is Bob McClellan, and I am a co-chair of the Action Collaborative on Business Engagement and Building Healthy Communities, and I'd just like to welcome you all to this one of a continuing series of webinars. Today is actually one of a pair of webinars that will be put on by a collaboration between Robert Wood Johnson and Academy Health. The next webinar, for those of you who want to be part of both of these webinars, will be on October 21st at the same time, and that one is titled How Businesses Can Engage in Community Health and Considerations for How to Better Target and Develop Their Investments and Research Insights Regarding that Topic. Today, however, we will be talking about why businesses should invest in community health. And to moderate today's session, I'm pleased to introduce to you Dr. Mona Shah, who is a Senior Program Officer with the Robert Wood Johnson Foundation. Prior to that position, she served as an Associate Director of Federal Relations at the American Cancer Society, Cancer Society's Cancer Action Network in Washington, leading and executing the organization's strategy related to prevention, access to care, safety net programs, and health disparities. She received her PhD in epidemiology from George Washington University. So, Mona, I'm going to turn it over to you, and I look forward very much to this webinar.
Thank you, Bob, and thank you to Alina and the National Academy's team for inviting us to present this research today. So as many of you know, RWJF is focused on building a culture of health. A critical aspect of a culture of health is health equity, which in essence means we all have the basics to be as healthy as possible. Yet at present, far too many of us, the prospects of good health are limited by where we live, how much money we make, or discrimination we face. So at RWJF, our programs, our strategy, and our research are meant to show how community health has a potential to prevent disease and injury and improve individual and community prosperity. We recognize that the pursuit of community health requires a range of strategies and a range of partners, including efforts to change community conditions in order to ensure everyone has the opportunity for better health and well-being. So this means access to good quality jobs, high-performing schools, affordable and stable housing in safe neighborhoods, and access to quality medical care. We all benefit when everyone has the opportunity to live in a place where conditions promote health and well-being. And we believe businesses have a role in helping with community health. However, a major question remains is how can businesses impact the health of a community? And that question resulted in a call for proposals in 2017, and we're grateful that two of our researchers, Ron Getzel and Megan McHugh, are presenting their findings today. In 2017, we funded 8 studies that are looking at that all take a different lens of how we make the business case for health and population health. And next slide. Is there a way to move the slides? Great. The full portfolio of the studies are listed on this slide, so if you go to there, you could see a summary of the 8 studies, and many of them have results that you could look into as well. Next slide. So as Bob mentioned, this is the first of a series of 2 webinars that feature some of the studies that we funded in this call for proposals. The one today is focused on the bi-directional nature of community health and business success. Megan will be focusing on the manufacturing communities, and Ron will be focusing on business investment and workplace culture of health. And then in 2 weeks, as Bob mentioned, there'll be another 2 research presenting their findings, one looking at the incentives, financial incentives, and working with the YMCA, and then the second is working with multi-family housing developers who've implemented health strategies into their project. So thanks again for the invitation to present, and I'll turn it to Ron Getzel, who's the Vice President of Consulting and Applied Research at the IBM Watson Health and Senior Scientist at Johns Hopkins University, and he'll be presenting his work around the business case for employers' investment in healthy workers and healthy communities.
Thank you very much, Mona, and thank you, Bob and Alina and the National Academies for inviting Megan and me to present today. And I'll just ask, is it Alina, are you moving the slides forward? If you can go to the next slide. All right, thanks. So we'll start with the definition of culture of health, which Robert Wood Johnson Foundation has coined and has been very vibrant over the last few years. So culture of health is one in which good health and well-being flourish across geographic, demographic, and social sectors, fostering healthy, equitable communities, guides public and private decision-making, and everyone has the opportunity to make choices that lead to healthy lifestyles. And our focus is on the workplace, and the reason for that is because 160 million Americans go to work every day, and they spend the majority of their waking hours there during weekdays. So why not leverage the workplace as an opportunity to increase awareness, provide training and behavior change, and also to help people achieve their overall health and well-being. Next slide. So we were given a grant by the Robert Wood Johnson Foundation a few years back to basically do a formative research, process evaluation, to go out there and actually go out with journalists and visit some companies that have done an extraordinary job in creating cultures of health and learn from them directly, learn from their employees, from their senior executives, from people running these programs, to learn what does it take to have an exemplary workplace health and well-being program and to establish this culture of health. We published our findings, and the next slide shows the companies that we visited. These are companies both large and small. The large ones you can see are companies like Johnson & Johnson and Citibank and USAA, who have earned the C. Everett Koop Award, but also some smaller companies, in fact, some manufacturing companies, some as small as 200 workers who had extraordinary programs. Next slide. And what we did was boil this down to kind of the secret sauce or the 10 magic ingredients for success. And I won't go into details, but you can see at the top of the list is establishing a culture of health. One that employees feel when they enter the company doors. In fact, one of the CEOs talked to us and said, at the end of the day, we want our employees to feel healthier at the end of the day than when they first walked in that morning. So creating the programs, the strategies, the environmental supports, benefit plan design, budgets, engagement of workers, all those things matter. And obviously leadership is critical to that. And then number 10 on the list, something that is often left out, is having an effective measurement and evaluation framework. Next slide. So the project we did with Robert Johnson Foundation was to ask this very basic research question: do businesses that invest more in employee health and community health outperform businesses that invest less, as indicated by trends in their employees' health risk profile, medical expenditures, and even stock price? Next slide. So the two big ideas were, let's go out and measure something called internal culture of health, which are the activities, programs, policies, and environmental supports that are developed and executed by a business to improve the health and well-being of its workers. But secondly, let's also investigate external culture of health. Similarly, activities, programs, policies, and environmental supports that are developed and executed by a business to improve the health and well-being of their communities. Next slide. So to do this, you've got to build a logic model and look at what causes what else and how the logic flow works on this. So on the internal culture of health, actually there's been a lot of research out there, a lot of evidence accumulated over 3 or 4 decades that says these things are possible. And here's a logic flow that if you invest in internal culture of health, you do things like provide leadership commitment and support, strategic communications, social and physical environmental supports, programs and policies, that in turn will lead to better self-care, better healthcare management, improve reputation and brand of the company, improve worker morale, ease in attracting and retaining talent, more skilled and devoted workers, which in turn leads to increased productivity and innovation, reduced cost of doing business, improved business performance, and then ultimately the 3 main outcomes of interest: improved employee health, lower employee healthcare costs, and improve stock performance. So that was the logic flow for internal culture of health. Next slide. Before we get to the next slide, actually, there is good prior research, especially, we can go to the next slide, especially in the area of internal culture of health. There have been many studies, and here focusing specifically on studies that look at the performance on business outcomes. This, for example, looked at the HERO scorecard, which is an organizational health assessment, and it demonstrated that those companies that have high scores on the HERO scorecard, actually their healthcare cost trends go down as compared to those that have lower scores. Next slide. We also looked at the companies that score high on the HERO scorecard and their stock performance, and indeed their stock was better, their performance over several years was better than the S&P 500, the Standard & Poor's 500. Next slide. And then we looked at a long-term view, actually going back to 2001 through 2014, and created this imaginary stock portfolio of winners of the C. Everett Koop Award. And there were 26 companies that have won the award that are publicly traded and met the inclusion criteria for that study, and found that those companies over that entire time horizon outperformed the S&P 500 by a ratio of 3 to 1. Next slide. But when it came to looking at external culture of health, again, these are things that companies are doing to invest in their community, it was much harder to do this. This is still the logic flow. The first step was basically operationally define what you mean by investing in external culture of health. And some of the things that we came up with based upon our interviews with subject matter experts, charitable giving, support for employee volunteerism, organizational commitment, and public leadership, especially in the areas of community health. That in turn should influence improved reputation and brand, better stakeholder relationships, healthier, more vibrant communities, that influencing improved worker morale, ease of attracting and retaining talent, more skilled and devoted workers, increased productivity, reduced cost of doing business, improved business performance, and then again back these three main buckets of improved employee health, lower employee health care costs, and improved stock performance. Now, the reason I'm showing this logic flow is to show that there really is no straight line relationship between things on the left side and things on the right side, that you've got to go through all these various ventures and various mazes in the on the chart here. And a lot of that basically calls for needed research to show those relationships, to show that one of these boxes influences the other box. And by the way, there are relationships that go in both directions. Next slide. So what we did in our study was, first of all, we recruited 38 employers that met our inclusion criteria, and that included being in our data set. So we've got a very large normative database called MarketScan, which aggregates and de-identifies data from over 100 employers who are the customers of IBM Watson Health. So we already have their person-level data in that database. We needed to apply certain inclusion-exclusion criteria and also get them to agree to take two surveys, one focused on an internal culture of health, the other on an external culture of health, and look at those scores over time, over a 3-year time horizon, because we wanted to look at trend. We then connected the survey data from 32 of the employers that did comply and did respond to our initial call for inclusion participation in the study. We linked their data from the surveys to the IBM MarketScan healthcare database and claims data, and also Health First database. Ended up with close to 1 million workers in that database. We use regression analyses to estimate the association between changes or increases in culture of health and employee health risk profile, healthcare utilization, and then finally we compared the high and low culture of health companies to their stock performance compared to the S&P 500. Next slide. So the data sources were an internal culture of health survey, an external culture of health survey, the MarketScan database, and their stock price data. Next slide. Next slide. So to develop the internal culture of health survey, that was actually quite useful, quite easy to do, because there's a lot of precedents out there, a lot of surveys that have been done in the past where we could borrow certain items, certain survey questions from those surveys. We primarily relied on the CDC Worksite Health Scorecard, which, if you don't know about, is newly updated in this year. It's up on the CDC website. It has 18 different modules with 154 questions. We focus primarily on the first module, which is organizational support for health and well-being in the workplace. And we came up with the 24 items and the 6 subscales, again, leadership, commitment, and support, communication, engagement strategy, programs and policies, physical activity, nutrition, psychological well-being, and participation in programs. And we then created an index that scored each of the companies on their internal culture of health. Next slide. So the external culture of health was a lot more complicated because no such instrument already existed. We had to basically come up with a brand new instrument de novo. We had a lot of discussions and focus groups and talked to a lot of subject matter experts on this topic, did literature reviews. The idea was to come up with specific behavioral operational definitions for what it means when a company actually invests in community health. And it turns out that wasn't quite easy to do. We came up with an instrument with 39 items, 16 of which were determined to be core items and could be used for scoring purposes. Next slide. And these were the categories that we ended up with in terms of those items that were scoreable. Again, organizational commitment, employee volunteerism, charitable giving, and public leadership. Next slide. So there were 3 papers that came out of this research. The first one actually looked at the psychometric characteristics of both the internal and external culture of health instruments. And one thing that we found surprising was that there was actually very little correlation between scores on the internal and external instruments. In other words, companies that scored high on one didn't necessarily score high on the other. In fact, there was very little relationship between the internal and external scores. And we commented that this is probably because these functions in an organization are in separate silos. So you have the health and well-being and occupational health and safety department and benefits people and medical people and all that all in one category. And then you've got the public affairs and the marketing people and the government affairs people all somewhere else in another part of the organization. And there's very little cross-communication that goes on between those 2 organizations. So not surprising that there was very little correlation in terms of whether they scored high or low on these culture of health assessments. Next slide. So looking at each of these instruments separately, what we found was when we looked at culture of health and changes in culture of health, primarily improvement in those scores over a 3-year time horizon, that was associated with statistically significant reductions in alcohol use, blood pressure, depression, nutrition or diet, tobacco use, and weight. And this was gathered through individual health assessments that these employers collected for their workers over this 3-year time horizon. The opposite was found in terms of stress. Stress was actually shown to increase even though the culture of health of the organization, internal culture of health, actually improved. In terms of healthcare utilization, we saw a reduction in annual pharmacy fills, but no statistically significant differences in costs or in other indicators of healthcare utilization. Next slide. Looking at external culture of health, here again, and this was actually, we found very little change, very little movement in external culture of health. So actually it was a snapshot in time. Organizations really didn't change very much in terms of their reporting of what they were doing to improve culture of health. So it was really a cross-sectional analysis, but we did find improvements in overall cholesterol levels, blood glucose, stress, and tobacco use for those companies that had high external culture of health scores, but actually an increase in depression risk over time. Here, in terms of utilization, we found reductions in inpatient admissions and emergency department visits, but again, no impact on overall medical spending and some of the other risk factors that we were studying. Next slide. So the third study that we looked at was looking at stock price, and this was intended to capture the attention of chief financial officers at companies who are looking at internal and external culture of health. Next slide. So for the first study, the first analysis where we looked at the internal culture of health and those companies scoring high on internal culture of health, looking at their stock performance over time compared to the S&P 500, we found that they outperformed. They did better than the S&P 500, whereas the Standard & Poor's went up 69% between this period of early 2013 through late 2017. Overall stock price had increased about 69%. Those companies that had higher scores on internal culture of health did better. Their stock price went up 115%. Next slide. But the opposite was found for those companies that had high external culture of health scores. Actually, again, 69% was the overall increase in the stock market for this time horizon, just under 5 years. But those companies that reported high external culture of health did worse than the average. Their stock did go up, but it only went up 44% compared to 69% for the overall market. Next slide. So the conclusions of our study was, number one, it's important to measure organizations' efforts to build culture of health both internally and externally. Secondly, companies building and improving their internal culture of health have been shown to reduce employees' health risks, healthcare utilization and expenditures, not just in this study, but also in other studies that we've conducted. Thirdly, there's growing evidence that companies that care about workers' health, safety, and well-being outperform the S&P 500. There are about half a dozen studies now that have been done with different companies, different populations, different time horizons that have shown that relationship. And fourthly, more research is needed. Focus on measuring and evaluating corporate efforts to build and sustain strong cultures of health in the community. Next slide. And these are the publications that came out of our RWJF studies, if you're interested. And with that, I will turn the floor over to Megan. This is Ron. I can't hear anyone else. Should we be pausing for questions, or is Megan trying to get on? Oh, she's muted, she says.
Right. Hang on just a moment. We had a technical problem on our end that crashed our system.
Oh. While we're waiting, Bob, I can respond to your question if you like.
Great.
Sure, that'd be great.
Okay, so Bob is asking, what extent do you think superior stock performance is due to overall superior management leadership? So in the study that we published here and also in the COOP study, we basically said this is bidirectional, that good leadership is one that promotes worker health and well-being and deals with organizational issues, stressors, demands, latitude, all those things that are important. And then consequently, employees potentially are more loyal and more committed and less likely to leave the company. So it goes in both directions, we think. Those things kind of go on parallel tracks. So I don't think anyone can point to a cause-effect relationship in any of these studies. But there's a lot of evidence out there, and we cite a lot of it in our research, which shows that those companies that are the best companies to work for example, on a number of different lists, are also those that have superior stock performance.
All right, great. Makes sense. Thank you.
Well, thank you for your patience. I think I've been unmuted. Would you like me to begin?
Please.
Yes, please.
Hi. Well, thank you, Bob and Elena and Mona. I'm honored to be a part of this panel, and I'm proud to be able to say that I previously worked at the National Academies. I actually worked at the Institute of Medicine years ago, and I have a lot of respect for the work that the organization does, and so I appreciate the invitation to join you today. So today I'm going to share with you some of the findings from a few studies that my colleagues and I have been conducting at the intersection of community health and manufacturing. And specifically, I'm going to be making the case that there's an opportunity to engage large manufacturers in community health improvement efforts. And I believe there's an opportunity for policymakers to advance manufacturing industry interests by investing in community health and manufacturing communities. So next slide, please. I'm going to begin by just spending a minute or two on the manufacturing industry in case it's not terribly familiar to folks, and it wasn't terribly familiar to me before I started this line of work a few years ago. But the manufacturing industry employs about 12.8 million workers, which represents about 8.5% of the total U.S. workforce, and it accounts for about 12% of the U.S. economy. Now, there has been a fairly large decline in the manufacturing sector over the past 50 years or so, largely due to automation. But the industry has been growing again, thanks in part to favorable public policies. Next slide, please. So 2017 was actually dubbed the year of the manufacturer. And if you were following the news at the time, you know that the Trump administration had been very vocal about bringing back manufacturing. And the administration supported the industry through deregulation and through the tax cuts. And I'm not going to go through this list that you see here on your slide, but it's a list of regulatory wins for the manufacturing industry under the Trump administration. And this list was developed by the National Association of Manufacturers. Next slide, please. And surveys from the National Association of Manufacturers showed that industry optimism reached unprecedented highs, first in 2017, then again in 2018, and then again in early 2019. But if you've been following the news in recent days and weeks, you know that there have been some trade uncertainties that have been causing a lot of concern for manufacturers in the past in the past month or so. So now we're actually seeing a little bit of a slowing in growth in manufacturing and some dips in industry optimism. But nevertheless, manufacturers have added almost 500,000 new jobs under the Trump administration, and the unemployment rate in manufacturing is at 3.2%, which is below full employment. So manufacturers are reporting that hiring a qualified workforce is their biggest challenge, and they're having difficulty filling not only skilled positions but unskilled positions. It's a very tight labor market for manufacturers. Next slide, please. So speaking of the manufacturing workforce, manufacturing workers tend to be less healthy on average than workers in other industries. They have higher rates of poor health behaviors like smoking and binge drinking and poor health outcomes. And what we see is that these poor health behaviors and poor health outcomes also hold at the community level. So we see that heavy manufacturing communities have higher rates of poor health behaviors and poor health outcomes compared to other communities. And many manufacturing communities, of course, have been hard hit by the opioid epidemic. Next slide, please. So the relationship between large manufacturers and the communities in which they're located is a really interesting one. It's sort of a symbiotic relationship here. The community supplies the company with a labor force, and the company provides the community with jobs and economic stability. And for the purposes of our research at Northwestern, we're really interested in focusing on the communities that have a single large manufacturer that serves as the largest employer in the community and really dominates the economic activity of the community. So think about companies like Caterpillar in Peoria, Illinois, or Dow Chemical in Midland, Michigan. Next slide, please. Now, health also plays an important role in this relationship. If the community is not producing workers who are healthy in terms of both their physical and their mental well-being, that's going to have major implications for the company in terms of their healthcare spending, for productivity, and for the culture of the organization. Further, we know that company policies can influence the health of the community. For example, whether a company decides to offer health benefits or not, or the working conditions within the plant, or the organization of shifts for their shift work policies can all affect the mental and physical well-being of the community. And although this relationship that I've just described is intuitive and conceptually appealing, and there's not a whole lot of disagreement around this relationship, there's also not a whole lot of evidence behind it. And this is a gap that our research team has been trying to fill. Next slide, please. So to that end, last year we published a paper showing that poor community health was associated with poor employee performance in large manufacturing plants. So using employee-level human resources data from 2 large Fortune 500 companies, we were able to show that employees who were living in communities with high rates of poor community health had significantly higher rates of absenteeism and tardiness. And for simplicity's sake, I'm just showing data on this slide from one company, but you can see that employees living in counties with a large percentage of children on free or reduced lunch had rates of absenteeism and tardiness that were about 2.7 times higher than other workers. Similarly, employees who were living in areas with high rates of physical inactivity, they had rates of absenteeism and tardiness that were about 2.6 times higher than other employees. And this relationship held for other measures of community health, including drug overdose deaths and adult smoking rates. Next slide, please. So our statistical results were really well aligned with the data that we gathered from interviews with plant managers and focus groups with the assembly line workers. And when we asked about how the health of the community impacts the work that went on within the plants, we often received responses like this one that I'm just going to read to you. Actually, that's probably our #1 issue with people now missing work because of stress-related issues, often from an outside family issue. I hate to say this, but more people are getting into drugs and alcohol abuse and stuff like that. There was a lady who quit the other day because of a family member. She felt like she needed to stay home and take care of her family member because they have a bad drug problem. So the hourly workers, the assembly line workers, reported to us that poor community health in the form of poverty, caregiving burdens, family dysfunction, substance use, all negatively impacted their performance at work. And specifically, they reported to us that it created what they often referred to as mental stress, which led to not just absenteeism and tardiness, but distraction, irritability, and more rarely, lapses in safety. Next slide, please. So we also conducted another study that was funded by the National Association of Manufacturers that looked at the opioid epidemic in manufacturing, in the manufacturing sector, and specifically in manufacturing communities. And we interviewed leaders from 22 companies, and we found considerable variation in terms of whether the opioid epidemic had affected their companies and productivity and worker performance. But in the areas where the opioid epidemic was bad, the impact on the companies was really, really tremendous. For example, one gentleman, he was an owner of a company, reported firing over 200 employees over the course of 5 years due to substance use issues. And I'm going to share with you a quote from a company leader that demonstrates even a more extreme case of how the opioid epidemic is affecting businesses. Next slide, please. If we don't fix the opioid issue, we would have to think about shutting down the plant and moving somewhere else. Right now, our problems are localized in 2 plants. We could outsource. We have plants outside the US. If the problem gets worse, it might be a choice we're forced to make. So again, more evidence of community health affecting business. Next slide, please. So given that we know that poor community health is prevalent in manufacturing communities, and we know that it negatively influences worker performance, we sought to better understand the extent to which large manufacturers are, in fact, investing in the health of their communities. We know that virtually all large employers engage in corporate philanthropy, but what we don't really know is the extent to which it's directed towards improving community health. So specifically, we sought to better understand how corporate giving decisions were made, whether companies were directing corporate philanthropy dollars to improving community health, and whether companies were coordinating their corporate philanthropy dollars with local public health leaders. Next slide, please. So to answer these questions, we conducted telephone interviews with leaders of corporate philanthropy from 13 Fortune 500 companies. Our semi-structured interview protocol was designed to collect information about the company's philanthropic efforts at the national level, but also at the local level in at least one community where the company served as the largest employer in the community. I'm happy to talk further about our analysis if folks in the audience are interested in hearing more about it later. Next slide, please. So what we found was that The direction for corporate giving was largely set at the national level or the corporate level. Each company identified a small number of priority areas that aligned with the company's mission. So for example, we heard from a food manufacturer that their corporate philanthropy was focused on nutrition activities and programs. We heard from a tool manufacturer that their corporate philanthropy was focused on improving affordable housing within their communities. The amount of money that was provided locally was also determined at the corporate or the national level. And nationally, corporate philanthropy dollars were quite sizable, often described in tens of millions of dollars each year. And those are actual dollars, not dollars associated with any volunteer time that their employees contributed. We also learned that companies directed their giving largely to the communities where they had a major presence, like a big manufacturing plant, rather than spreading out their giving nationally. And although that overall direction for giving was set at the corporate level or the national level, decisions about which organizations and programs to fund were often made by local employees, typically representatives from, HR or legal or plant leadership. We heard a lot about partnerships with the United Way and the benefits of partnering with the United Way for corporate giving. And I want to point out that we didn't specifically ask about the United Way, but it came up in conversation with most of our respondents. They identified the benefits being that the United Way has deep connections in the community, and they tended to be a little bit more sophisticated than other not-for-profits in terms of being able to develop a strategy for how they were going to spend the money and a strategy for holding themselves accountable for spending. We asked whether giving was directed towards improving community health, and overwhelmingly, we were told that it was not. Next slide, please. I think that this quote nicely represents the sentiment of several of the respondents who participated in our study. The company spends so much to pay for health insurance for our employees. We have lots of corporate health-related things that our corporate medical group works on. We don't want corporate philanthropy focusing on that. Next slide, please. Nevertheless, the priority areas for corporate giving identified by the respondents in our study aligned very nicely with the social determinants of health. And if you're not familiar with the social determinants of health, these are the factors that shape the condition of one's life and ultimately one's health. It is, these 6 factors are well known in the field of public health, and these are the areas that we need to improve if ultimately we want to improve community health. So as you can see, 6 of the companies that we spoke to said that improving education was their priority, and 4 companies said that food and nutrition programs was their priority, so on and so forth. So the bottom line is, although companies told us that they didn't necessarily want to direct corporate philanthropy towards improving community health, they are in fact investing in community health, whether they realize it or not. Next slide, please. When we asked our respondents about the biggest challenge that they faced in corporate philanthropy, many said that measurement and evaluation was their biggest challenge. And they said that it was difficult to determine the impact of their giving and whether they were making the right choices. So for example, one respondent said, "The social issues that we're investing in are some of the most intractable problems facing our country. How do we make sure that we are directing our limited resources to the things that are producing the most value?" Although the companies said that they were struggling with decision-making about how to best spend their philanthropy dollars, they said that they generally didn't seek guidance or partnerships with local public health leaders. Next slide, please. So in conclusion, our research shows that manufacturing workers and communities are relatively unhealthy, that unhealthy communities are negatively impacting productivity in large manufacturing plants, and that large manufacturers are in fact investing in the social determinants of health, but they're doing so unknowingly, without much evidence, and without public health partners. Next slide, please. So 2019 really represents a unique opportunity to engage large manufacturers in efforts to improve community health. And that is because manufacturers right now are acutely feeling the effects of poor community health. as they're trying to hire more workers, as they're trying to fill these open positions. They're having difficulty finding qualified people locally, and they're struggling to recruit people from other places because they're often hearing that their communities are undesirable places to live. So if there was ever a time to engage large manufacturers, I would offer that the time is now. So our findings point to a couple of suggestions. And the first is that local public health leaders can sort of elevate the recognition given to large manufacturers for investment in community health. I mean, again, these companies are investing in the social determinants of health where they have a major presence, and public health departments could potentially view them as partners. And this means sharing results of community needs assessment. It might be inviting representatives from the companies to participate in developing strategic plans. I'm sure there are other strategies as well. Additionally, public health leaders could potentially share their data and evaluation expertise with the companies. Public health officials often have access to population level data that the companies probably do not have, but they are data that could potentially be used by the companies to identify improvement over time. Additionally, a lot of public health officials and staff are trained in the field of evaluation, and they could potentially help the companies develop a strategy for evaluating the impact of their corporate giving, thereby addressing the greatest challenge encountered by corporate philanthropy leaders. And then finally, as I mentioned earlier, certainly the Trump administration has been really supportive of manufacturing in terms of deregulation. But another way to support the industry would be to invest in community health in manufacturing communities. That would have the dual benefit of supporting the companies, supporting the industry, as well as improving population health. It would also, signal support for the people who are actually doing the hard work. Next slide, please. So I appreciate your attention. All of this work that I described was part of Northwestern's program on manufacturing and health, the goal of which is to generate evidence to improve the health of manufacturing employees and communities and to reduce healthcare costs for the company. Thank you for your attention, and I look forward to the conversation.
Thank you, Megan and Ron. This is Megan Collado at Academy Health, and we have a lot of time for questions, and I see a number have come in during your presentation, so I will pose them to you. Some were for Ron that came in during his early remarks. Others came in for Megan, and then some I think are for both of you. So I'll just start in the order that they were submitted. Ron, we got a question during your presentation about who completed the survey. I'm interested in the stress. Oh, maybe this is Megan. Let me go back to this. I'm interested in the stress finding. How representative are the claims? What proportion of workers are represented in the claims data? Mostly full-time benefited employees. What about those in precarious work arrangements, part-timers, contracted?
Yeah, so let me answer. Yeah, maybe to me, and I think also there was a question to Megan about the people completing the surveys or the interviews. For me, it was people in the companies who had kind of a broad view of internal culture of health initiatives, mostly in the benefits, health promotion area, occupational health and safety, medical departments, EAP, and so forth, were the people who completed the internal and internal surveys. The external surveys were primarily public affairs, government affairs. The public-facing arm of the companies completed those surveys. In terms of the question about stress, actually what we did was connect health risk appraisal data and claims data. So when we're looking at stress, for example, it's derived from HRAs, or health risk appraisals, where people report that they have high levels of stress and are unable to cope with that stress. So that's the source, looking at the risk profile of the population, and then the claims data were used for utilization and cost outcomes. So inpatient admissions, outpatient visits, emergency department, prescription drugs, and overall spending came from the claims data versus there were 9 risk factors that we looked at in terms of health risk data.
Thanks, Ron. And another question for you was, is there a proxy for stock price that would provide a good measure for non-publicly traded companies to use?
I'm not familiar with how that works and whether it's donations, endowment, growth, things like that. I don't know, but I'm sure people in the nonprofit arena probably have good metrics that they look at. But yeah, nonprofits or even privately held companies that don't list on the public stock market, it's hard to look at their business performance compared to norms. You can look at revenue and profitability and return on capital and things like that. But I think for each level of organization, whether it's profit or nonprofit, they probably have their own metrics to look at their overall success as a company.
Great. And then a question for both of you. What recommendations do you have for small businesses?
I'll start, Megan, you can jump in. Certainly, any business, any size business can go to any of the scorecards that are out there. I mentioned the CDC Worksite Health Scorecard. That's available to everybody and actually primarily designed to help small businesses adopt and apply evidence-based practices in their workplaces. And those are programs, policies, environmental supports, things that are quite simple and low cost, all the way to things that are more intensive and more expensive to put in place. Hero Scorecard is another example of an organizational assessment tool. The American Heart Association has something called the Workplace Health Achievement Index. And there are about a half a dozen other scorecards that companies can use to focus on internal culture of health. On external culture of health, I don't quite know. Megan, you have some insights as to where companies can go to come up with best practices on how to improve the health communities.
Mm-hmm. Yeah, so our research is focused primarily on, again, large businesses, large manufacturers, because we believe that these are the organizations that really have the heft to move the needle within a community. And I would submit to you that small businesses, don't have the same power to do that. Now, nevertheless, small businesses can serve as a catalyst and sort of tip the scales within their communities. So if the larger organizations, as I just described, aren't partnering with local public health, well, small businesses can. And small businesses can, put a bug in their ear to start working with the larger businesses. So it's sort of like, I think that their best approach is serving, again, as this catalyst, rather than expecting a small business to change the culture and dynamic within the community on their own.
Let me just add to Megan's comments that I think chambers of commerce in communities probably have a lot of leverage, and they are often comprised of small businesses and large businesses. So when businesses come together as a chamber and focus on specific problems that are relevant to that community, I think that can have tremendous leverage opportunity to improve community health.
The next question is, did either of you have any interview questions focused on work itself as a social determinant of health?
Well, I can tackle this one. So for our study, we specifically developed questions that were really geared at how the health of the community affects the work that goes on in the manufacturing plants. And I will tell you, during our focus groups, inevitably, in every single focus group we conducted, our participants shifted the conversation in the opposite direction, arguing that it's really the company that affects the health of the community. And what we heard more and more about was two things. One, that a lot of the work in large manufacturing can be isolating, and this could lead to mental health issues. And then the second and bigger thing we heard about was shift work. 12-hour shifts, rotating shifts, uncertain schedules were really wreaking havoc on a person's physical and mental health, and then creating problems within families, trying to balance work and home life. And so we have actually taken, even though it was outside the scope of our original intention, we heard that story so frequently that we're actually writing up those results now.
Yeah, and I can respond also. The organizational section of the Worksite Health Scorecard has 25 items in them that do touch upon and deal with work itself, things like work time flexibility, managerial training, pay, benefits, wages, accommodations, for example, for nursing mothers, physical design of the space, and overall benefits. So there are many elements in that section of the CDC scorecard that deal with work itself. And there are sections in that scorecard that are specifically focused on occupational health and safety, musculoskeletal disorders, stress, depression, and so forth. So if you look at it as a totality, yes, there are many factors that are work-related that are included in there.
The next question is for both of you. Do you think that having health professionals on the company boards would improve investments in community health?
I think I would sort of reword it a little bit and say that public health professionals or community health professionals on company boards could potentially improve it. Because what I'm often seeing is, that companies recognize that their workers aren't healthy. They're ultimately playing the claims, and so they know there's a problem here. And the interventions that I often hear about are things like, okay, well, we'll get a medical facility on site. We'll hire a full-time physician to work in the plant, or we will use our leverage and encourage local primary care physicians to implement PCMH, patient-centered medical homes. Or we'll give our employees health risk assessments. And all those things are good things, but again, it's just kind of focusing on the physical health of the employees, whereas, I see this as a bigger problem. And I don't know that a medical professional can address this as well as a public health professional.
Yeah, I agree 100% with Megan. In fact, we were both working and have worked with the Beaumont Foundation in Bethesda, Maryland, and Bipartisan Policy Center here in Washington, basically making the point that in order to have cooperation, collaboration, you need to have people who understand both worlds, the public health world as well as the business world, people trained in business, people trained in public health. And most of the people that you would put on a board would be physicians or hospital administrators, but they're dealing with treatment issues, how to get people the right care, the right medication, the right procedure, versus upstream looking at the social determinants of health, which may include housing and poverty and job design and education and all those things that Megan mentioned earlier. So if you have those people on your board, that's great. But I also would encourage companies to become part of a coalition in the community that includes the public health department.
Great, and your comments align nicely with a participant who commented after that question to say one challenge with health professionals is the tendency to think in terms of medical care rather than the social health opportunities beyond health care, which I think you both spoke to. A follow-up question for Ron. Have you ever compared expert reports from HR on culture of health surveys to employees' answers?
Yeah, that is being done. It hasn't been done enough, but I think that's an important research opportunity for everybody, which is to look at what the company officials think they have in terms of culture of health and also compare that and contrast that what employees' opinions are. And often it's very easy to get those kinds of opinions. We actually embed those kinds of questions in our surveys where we ask things like, what is the culture of health in this organization on a 5-point scale? Or do you feel that your leaders, the company, supports your health and well-being, provides you opportunities to improve health, and those kinds of things, which are from the employee standpoint. And then we can compare and contrast that to what the company is saying in terms of its own self-assessment on organizational health metrics and tools. So, and the gap, the delta between what the company thinks it's doing versus what the employees are thinking is obviously the gap for opportunity for intervention and investment. So I think that ought to be kind of the next horizon in terms of research here, where we do connect the dots between organizational health and individuals' health and well-being.
Great, and we got a question from a participant who asked whether either of you are willing and available to speak to other audiences in another state if an event could be set up.
Yes.
Always, yeah.
I think Ron and I do this quite a bit.
Yeah, especially if it's like Hawaii or something.
Yeah, please feel free to reach out. This is Megan Collado. You could reach out to me and I could connect you to Ron and Megan, or I think both of them have their contact information in the slides, which I think will be sent around. So please feel free to reach out. And the next question is a follow-up for Ron. Improvements in community health are likely to require long-term investments in multi-sector collaborations and perhaps even longer to affect employers, business, and health costs. Ron, could you provide more detail about whether you looked at businesses that you studied were part of a collaborative, or were their efforts independent? And also, over what time frame did you study the impact of investment in community health?
Yeah, we haven't done a whole lot of research on collaborative or coalitions. I think that is an opportunity, and I know that we've had discussions with Hero and Paul Terry there, and about how we might do this, actually, how to establish nationwide partnerships, coalitions at the local level, where you bring together the public health community, the health promotion community, and the business community, and they essentially create think tank and do tanks at the local level and then measure that over time. But this is indeed a long-term effort. This is something that's not going to happen overnight. You're not going to change individuals' health, never mind organizational health or even community health, overnight. I know Kathy Bossi has been working in mid-Michigan for many, many years to do that at the community level, and she's been very successful, but it does take a long while. It takes a long while to establish that mindset, that culture, and the actions that can be taken, and obviously measuring them over time. And that may be decades, not just quarters over time. So there is a challenge because companies, by and large, look at quarter-by-quarter results as opposed to 5, 10, 15, 20-year strategic plans. But that's what's needed, I think, to look at in the long view. That's not to say that you don't measure and report on the key findings on a regular basis, and that can be and should be at least annually, and to see if there's any progress being made on the key metrics.
Great, and we also had a comment from a participant who said, besides chambers of commerce, look in your state for a state coalition of employers that are members of the National Alliance of Healthcare Purchaser Coalitions. They might be even more interested in this issue. Looks like we've gotten one last question in here. We still have time, so if others have questions, please feel free to put them in. But the last one is a question for Ron. For those items in the scorecard that deal with work as a social determinant of health, did you do a sub-analysis to see if the odd stress finding was related to those factors?
Kim, we did not, no. I mean, there were many other sub-analyses that we could have done looking at again, we had 9 different risk factors we looked at. We had 4 categories of utilization and cost, and a whole lot of other data that we could have drilled down on. But no, we did not do those sub-analyses. Certainly, I think one of the limiting factors is just the number of employers who are included in the study, and there probably wasn't enough power to do a lot of those sub-analyses. But if we had hundreds of employers contributing data at the organizational and the individual level, I think some of those studies could be done.
So, Mona, this is Bob McClellan. I think we actually are at the top of the hour and the end of the time set aside for this. So, certainly on behalf of the Action Collaborative, I want to thank you, the Academy Health, the speakers, for a fantastic webinar, and certainly look forward to the next one coming up, which will talk about how to actually target, hopefully, effective investments in community health. As you can see on the splash screen now, these slides and a recording will be made available, not instantly. It usually takes a couple of days, it seems, to get up there, but it will be available for all participants to see. So again, thank you all, and I look forward to hopefully having you back in a couple of weeks.
Thank you.
Thanks so much, everyone.